Usually when we think about medicine, there's this comforting expectation of mass-produced precision, right? You have a headache, you open a plastic bottle, you take a pill.
Right, and every single pill is identical.
Exactly. Chemically identical to the last one, made in some factory hundreds of miles away to an exact milligram specification.
It's the whole standard model of modern pharmacology. It's predictable, shelf-stable, and, entirely uniform.
But when you step into a clinic offering advanced biological therapies, that factory line completely vanishes. Like you become the pharmacy.
You do.
So today, we're welcoming you to a deep dive into a really fascinating intersection of everyday physics, hematology, and women's health. We're looking at autologous platelet-rich plasma, or PRP.
Yeah, and specifically, we're diving into this whole stack of clinical guidelines and cross-sectional studies. We really want to understand how the mechanical extraction protocol, like literally just the spinning of a machine, physically alters a sample of your blood.
Right, to create a highly targeted biological medicine for mucosal and vaginal dryness.
Exactly. Our mission here is to kind of move past the marketing of PRP. It's often sold as this generic magic serum,
Totally, like a cure-all.
Right. But the literature we're examining today proves that this medicine is incredibly sensitive. The specific speeds, the G-forces, the methods used to process the blood, they actually dictate the exact concentration of growth factors. And those are what regenerate thinning, dry mucosal tissues.
Okay, so if my blood already has this, capacity to heal the tissue, why can't my body just fix the dryness itself? Like, why do we need to intervene with needles and centrifuges?
That is the big question. To answer that, we have to look at the underlying physiological problem.
Right.
For many women, particularly during perimenopause and menopause, declining estrogen levels trigger this massive structural change in the vaginal tissues.
Because it's not just passive skin down there, right?
Not at all. Vaginal mucosa is a highly dynamic, estrogen-dependent environment. Normally, estrogen receptors in the tissue actively signal your body to maintain a really robust network of local blood vessels.
And those vessels are bringing in all the nutrients, oxygen, and fluid.
Exactly. But when estrogen levels plummet, that signaling just stops. So the tissue is, it's essentially starved.
And the result of that starvation is vaginal atrophy. The tissue physically thins out, it loses its elasticity.
Yeah.
And because that vascular network shrinks, the natural blood flow decreases, which means the tissue simply stops producing its natural lubrication.
Which leads to chronic irritation, micro-tearing, and dyspareunia, which is just the clinical term for severe pain during intercourse.
Right, and historically, the medical field has just sort of thrown synthetic lubricants or systemic hormone replacement therapy at this.
Right, but PRP offers a completely different mechanism of action, mostly because it's an autologous treatment.
And autologous just means the medicine is derived entirely from your own body. No synthetic chemicals, no artificial hormones, zero risk of allergic rejection.
Yep, it's your own biology, just repurposed. And the star players in this process are your platelets.
Now, if you're like most people, you probably just know platelets as the tiny things in your blood that form a scab. They stop you from bleeding when you get a paper cut. They're the clotters.
They are the clotters, yeah. But clotting is really just their first act. If we zoom in on a microscopic level, platelets are packed with these tiny internal structures called alpha granules.
Okay.
Think of alpha granules as cellular cargo holds. And inside those cargo holds is this heavily concentrated payload of vital proteins known as growth factors.
And the gynecological and hematological studies we're looking at focus heavily on three specific ones, right?
Exactly.
Yeah.
Platelet-derived growth factor, or PDGF, transforming growth factor beta, which is TGF-beta, and vascular endothelial growth factor, VEGF.
Okay, so let's connect those alphabet soup acronyms to the actual problem of vaginal dryness. What happens when those specific growth factors are actually delivered into that starved, thinning mucosal tissue?
Well, they execute this three-pronged biological rescue mission. First, VEGF promotes angiogenesis. That's the literal sprouting and formation of brand new blood vessels.
So it restores the plumbing and the fluid transport that the tissue lost when the estrogen dropped.
Exactly. Then second, TGF-beta triggers massive collagen synthesis. That rebuilds the physical elasticity of the vaginal wall. And third, PDGF drives overall cell proliferation, which literally thickens the mucosa back to a healthy state.
Wait, so the platelets themselves aren't just like patching the whole biological spackle?
No, not at all.
They're more like microscopic construction formulas.
Yeah.
They show up to the site of the damage, and they don't do all the manual labor themselves, but they blow the whistle and call in all the raw materials.
Yes.
Like they call in the blood flow and the collagen to rebuild a damaged neighborhood from the ground up.
That is a highly accurate way to visualize it. They arrive, they dump their cargo holds full of blueprints and chemical signals, and those signals tell the local tissue to get to work repairing itself.
Which brings us back to the core question. If I have these microscopic construction foremen floating in my veins right now, why do I have to go to a clinic to get them to do their job?
Well, because in your circulatory system, those formin are incredibly diluted. For every single platelet in a drop of whole blood, you have roughly 20 heavy red blood cells plus white blood cells, and it's all swimming in this vast sea of liquid plasma.
So if a doctor were to just inject whole blood into your mucosal tissue, nothing therapeutic would really happen.
Right, exactly. You have to extract and isolate the formin. And the cross-sectional studies reveal that the physics of how you extract them completely dictates the potency of the medicine.
Okay, so this is where the physical extraction protocol comes in. If you're the patient, the process starts with a simple blood draw from your arm into a vacuum tube. But, and this is key, that tube is not empty.
Correct. The tube is pre-filled with an anticoagulant, typically a liquid called sodium citrate. This is a crucial first step.
Because platelets are literally designed to clot the second they leave the bottom, right?
Exactly. If you just drew blood into a dry glass tube, the platelets would immediately panic. They'd activate, clump together, and prematurely dump all those precious growth factors into the tube before the doctor even touched the centrifuge.
Oh, wow. So it would be ruined instantly.
Yeah. The sodium citrate essentially puts the platelets to sleep, keeping them intact during the spin.
Okay, so we have a tube of sleepy whole blood, and it goes into a centrifuge. Now, the clinical guidelines highlight what's known as a double spin method. Let's break down the mechanics of what's actually happening inside that machine.
Sure. So a centrifuge works on the principle of specific gravity. It's essentially sorting the components of your blood by their physical density. In the double spin protocol, the first step is called a soft spin.
Meaning the machine spins the tube relatively gently.
Right. This allows the heaviest elements, which are the dense red blood cells, to sink to the absolute bottom of the tube. What is left sitting on top is the liquid plasma, along with a very thin, cloudy layer called the buffy coat.
The buffy coat, that sounds so weird.
It does, but that buffy coat is where all your platelets and white blood cells are currently hanging out.
Okay, so the technician carefully siphons off that top liquid layer, completely leaving the heavy red blood cells behind in the first tube.
Yes. They transfer that platelet-rich plasma into a second, empty tube and put it back into the machine for the hard spin.
And the second spin is much faster and longer, right?
Exactly. The shear force drives the tiny platelets themselves out of the plasma and forces them to pack together into a concentrated pellet at the very bottom of the tube.
Oh, I see.
Then the technician discards most of the empty, cell-free plasma on top, mechanically resuspends that pellet of platelets into the tiny bit of plasma remaining, and that final liquid is your PRP.
Now we get to the core variable of our deep dive. The data from the cross-sectional studies shows that the actual G-force, like the relative centrifugal force pulling on those cells during these spins, profoundly alters the chemical cocktail.
It really does. It exposes the immense fragility of the biology here. One of the detailed studies we reviewed isolated the effects of different G-forces on the final platelet yield.
And what did they find?
They discovered that a very gentle first spin of 100 gram, specifically a double spin protocol of 100 gram, followed by a 400 gram hard spin, resulted in the absolute highest concentration of platelets.
How high are we talking?
We are talking up to 2.8 times the baseline amount of platelets you'd naturally find in your whole blood.
A 2.8 times concentration. That is a massive influx of construction foremen. And they measured the growth factors too, didn't they?
They did. And crucially, this specific 100 plus 400 gram gentle protocol resulted in the highest measurable release of TGF-beta1 and PDGF-BB.
Okay, and those are the exact anabolic growth factors we identified earlier.
Right, the ones specifically required to stimulate cell proliferation and rebuild the extracellular matrix, which is the structural scaffolding of the vaginal mucosa.
But wait. My instinct with medical technology, or, well, really any technology, is that faster and more powerful is inherently better. Like, if a clinic buys a top-of-the-line, high-powered centrifuge, wouldn't they want to crank that dial up to get maximum separation? Why does spinning the centrifuge harder, say at 800 gram, actually ruin the medicine?
Well, we have to remember what a platelet actually is. It's a highly sensitive cellular fragment. It's designed to rupture and dump its cargo the moment it experiences physical trauma, like the scraping of your knee on pavement.
Right.
High centrifugal forces create massive shear stress. If you spin these delicate cells at 800 grams in a plastic tube, the sheer physical pressure and friction traumatize them.
It's like putting fragile water balloons into a blender.
That's a great visual. Yeah, the centrifugal force acts as the blender. The platelets prematurely aggregate, they activate inside the machine, and they dump all of those precious growth factors into the empty plastic tube.
Oh, wow. So by the time the centrifuge actually stops spinning and the doctor draws that serum into a syringe to inject into the patient, the medicine is essentially empty. The foremen have already dropped the blueprints and vanished.
Exactly. The researchers found that a high-speed first spin at 800 grams actually decreased the final platelet concentration factor to below the baseline level of whole blood.
Below baseline. That's crazy.
Yeah, the resulting liquid was practically stripped of its vital regenerative potential simply because the machine was spinning too fast.
That fundamentally changes how you view a medical procedure. The machine isn't just prepping the serum. The physical settings on the machine are literally dictating the chemical makeup of the serum.
Absolutely.
And that brings us to the next major variable, the centrifuge controls, which completely shifts the biological signal, white blood cells.
Right. The clinical guidelines refer to this as the leukocyte dilemma.
Because speed doesn't just dictate how many platelets survive the spin. The G-force also acts as a biological filter for white blood cells, or leukocytes. And whether or not those specific cells end up in the final syringe completely changes how the vaginal tissue is going to react.
Yes, and the literature breaks PRP down into two main classifications based on exactly this. You have PPRP, which stands for pure or leukocyte-poor PRP.
Okay.
Through a very specific, gentle spin protocol, almost all of the white blood cells are successfully filtered out, leaving mostly just platelets. But on the other end of the spectrum, you have LPRP, or leukocyte-rich PRP. This protocol intentionally retains a high concentration of white blood cells alongside the platelets.
And what determines which one the patient actually gets?
Again, it comes back to the physics of the spin. Spinning the blood at higher relative centrifugal forces, like an 800 plus 400 gram protocol, forces the leukocytes to...
Let's define those for a second. If I remember basic high school biology, white blood cells are the good guys, right? They're immune system soldiers. They fight infection. Why wouldn't we want immune cells mixed into a healing serum?
Well, it's because of how they fight infection. Immune cells, like granulocytes, literally contain granules of toxic enzymes. They fight pathogens by triggering intense, localized inflammation.
Oh, I see.
So when leukocytes are concentrated in PRP, they release specific inflammatory cytokines, primarily interleukin-8 or IL-8, and tumor necrosis factor alpha, or TNF-alpha.
I mean, those sound incredibly aggressive. Tumor necrosis factor literally has the word necrosis, meaning cell death, right in its name.
They are aggressive because they're basically biological demolition crews. They break down old or infected tissue to clear the way for healing. Now, there are areas of medicine where a controlled inflammatory response from leukocyte-rich PRP is highly desirable.
Like where?
Well, if an orthopedic surgeon is treating a stubborn, chronically inflamed tendon, like severe tennis elbow, they might want LPRP. The tendon has essentially stopped healing, so the surgeon injects leukocyte-rich PRP to cause a massive wave of localized inflammatory chaos. It literally shocks the tissue into restarting the healing cascade.
Okay, but let's look at this from the perspective of the patient we're talking about today.
Yeah.
If you're the one sitting on the exam table seeking treatment for vaginal atrophy, you do not have a tough, fibrous elbow tendon.
No, you definitely do not.
You have incredibly sensitive mucosal tissue that's already irritated, burning, thinning, and actively causing you pain.
Which is exactly why the leukocyte content is so critical. If a clinician mistakenly injects leukocyte-rich PRP, which is packed with that inflammatory IL-8 into delicate vaginal tissue, they risk severely exacerbating the patient's pain, swelling, and irritation.
That sounds awful.
It is. For treating mucosal dryness, the gynecological literature strongly points toward a strictly regenerative anabolic signal. You want the low-speed leukocyte-poor PPRP. You want high levels of the collagen-building TGF-beta-1, but you definitely want to filter out the inflammatory cytokines.
So if you're visualizing the centrifuge weight, it's basically acting like an equalizer on a soundboard.
Oh, I like that.
Yeah, like by actively adjusting the dials of time and G-force, a clinician can turn down the inflammation bass and turn up the collagen-building treble, specifically to suit the delicate acoustic environment of the vaginal mucosa.
That is a brilliant way to conceptualize it. The clinician is using the laws of physics to actively tune the biological signal the tissue will receive.
So let's assume the clinic has done everything perfectly. They drew the blood with the right anticoagulant. They used a gentle double spin protocol at 100 grams and 400 grams. They tuned the equalizer perfectly to filter out the inflammatory white blood cells.
Okay, best case scenario.
Right. They now have a syringe full of highly concentrated, optimized leukocyte-poor PRP. The final step is actually deploying it to reverse the mucosal dryness. But as we established earlier, these platelets are currently asleep thanks to the sodium citrate. So how do they wake up to do their job?
Well, the platelets require a physical or chemical trigger to degranulate, to, open those cargo holds and dump their growth factors into the tissue. And the literature outlines two primary methods for this activation.
What's the first one?
The first is ex vivo activation, meaning it happens outside the body. The clinician manually adds a liquid activating agent, usually calcium chloride or a protein called thrombin, to the syringe right before they inject it.
What does adding calcium chloride actually do to the platelet, though?
It acts as a chemical override. It strips away the protective effect of the sodium citrate and essentially tricks the platelet into thinking a massive physical injury has just occurred.
So it panics again.
Yep, it forces an immediate, catastrophic release of the alpha granules. The studies show that when activated ex vivo, the platelets dump up to 70% of their stored growth factors within the first 10 minutes of the chemical being added.
Hold on, let me play devil's advocate here. If the doctor uses a chemical activator and 70% of these crucial growth factors are dumped in the first 10 minutes, doesn't that mean the actual healing window is incredibly short?
It sounds like it, yeah.
Like, if a woman has been suffering from menopausal vaginal dryness for 5 years, how does a 10-minute burst of proteins cure a chronic, long-term structural problem?
It's a very logical skepticism, but it goes back to our construction foreman analogy. The platelets themselves are not doing the long-term rebuilding. They are only delivering the blueprints and sounding the alarm.
Okay, I see.
That massive 10-minute chemical burst triggers a cascading biological reaction in the surrounding tissue. The sudden influx of TGF-beta and VEGF rings a cellular alarm bell, waking up your body's dormant local stem cells and fibroblasts.
And fibroblasts are essentially your body's microscopic collagen factories. Right?
Yes, exactly. The growth factors from the PRP tell those local fibroblasts to migrate to the area, set up shop, and start churning out new collagen and elastin fibers.
So the platelets clock out, but the factories keep running.
You got it. It is those secondary cells that actually take up residence and continue the heavy lifting of tissue regeneration. They thicken the extracellular matrix and restore the vascular blood flow over the following weeks and months. The PRP is just the catalyst, not the entire reaction.
But that makes perfect sense. The spark that lights the fire. So what's the second method of activation?
The second method is in vivo activation, where it happens inside the body. In this scenario, the clinician doesn't add any chemical triggers to the syringe at all. They simply inject the unactivated PRP directly into the vaginal mucosa.
So what wakes them up then?
They rely on the physical trauma of the needle piercing the tissue, combined with the fact that naturally occurring collagen fibers in the vaginal wall physically shear and rip open the platelets upon contact. This triggers them to slowly release their growth factors over several days.
So bringing this out of the laboratory and back into the examination room, what does this actual treatment look like for the patient? And more importantly, does the data show that it works?
The clinical procedure involves injecting this optimized PRP into specific areas of the anterior vaginal wall and the clitoral region. They typically utilize a topical local anesthesia cream for comfort. And the clinical outcomes measured in the literature are remarkably robust.
Because the targeted influx of growth factors successfully induces neovascularization, sprouting those new blood vessels we talked about.
Right, so the tissue finally begins receiving oxygen and plasma filtrate again.
And that plasma filtrate acts as the natural lubrication that had basically disappeared.
Precisely. The cross-sectional studies utilize a standardized metric called the Female Sexual Function Index, or FSFI. This index measures everything from physical lubrication and arousal to the psychological impact of pain reduction.
And what did the score show?
Following properly processed PRP therapy, patients show statistically significant long-term improvements across their FSFI scores. They also show vastly enhanced vaginal health index scores, which is a clinical measurement verifying that the physical integrity, thickness, and elasticity of the mucosa have been visibly restored.
That's huge.
It is. Patients report a return of natural lubrication, an end to the chronic burning and itching, and a dramatic decrease in pain during intercourse.
It is genuinely incredible what your own blood is capable of doing when it is optimized correctly.
Oh,
So,
yeah.
to bring this all together for you listening, the overarching takeaway from our deep dive today is that PRP is not a simple one-size-fits-all magic potion. It's an incredibly sensitive biological product.
Very sensitive, yes.
The clinical extraction protocol, the specific physical G-force of the centrifuge, the separation of inflammatory white blood cells, and the mechanism of activation literally dictates the exact concentration of growth factors capable of reversing mucosal dryness.
It's customized medicine in its purest form. The parameters set on the machine directly dictate the cellular efficacy of the treatment you receive.
Which brings me to a final, somewhat provocative thought for you to mull over. Because this field of biological medicine is evolving so rapidly, our sources point out a pretty glaring reality. There is currently no single, universally mandated machine or standardized protocol required across the medical field.
The lack of universal standardization is heavily debated in the clinical literature, actually.
Which means that two women could walk into two different clinics across the street from each other, ask for the exact same vaginal PRP rejuvenation procedure, and receive two fundamentally different chemical cocktails.
Yep.
One patient might receive a carefully tuned 100-gram gentle spin that maximizes collagen-building growth factors and filters out pain-inducing inflammation. But the other patient might get a high-speed spin from a different brand of centrifuge that traumatizes the platelets and fills the syringe with aggressive immune cells.
And the only difference was the physical radius of the centrifuge rotor, or the RPM dial chosen by the technician that morning.
It highlights the absolute necessity of being an informed patient. You aren't just asking a doctor for brand name treatment. You have to understand the science behind how they're physically manufacturing the medicine they are offering to you.
When the medicine is alive, the process is the product.
Beautifully said. We started this deep dive talking about the comforting, standardized precision of a factory-made pill. Biological medicine is the exact opposite. It's dynamic, it's highly sensitive, and its success relies entirely on understanding the physics of the spin. Until next time, keep diving deep.